could have set out in full why that change had been made and what evidence they had, which meant that it was an appropriate change to make. Because as I see it, we've been in a situation where we've had comments from bodies like the World Health Organization and others publicly disagreeing with our approach. So surely it would have been better to set out our position in full to give people the confidence that the vaccines would still work with that new dosing.
Well, thank you very much indeed. Actually, this was addressed at a press conference on the day that it was announced, or rather, there was a press conference on the day that this change was announced, and it was because it was the day that it was 30th of December, I think, the day that the Oxford AstraZeneca vaccine approval by the MHRA was announced, and we've communicated a huge amount since then, both publicly and privately, with communications, for instance, from Jonathan Van Tam, who's written very clear pieces about why we've acted, and privately to MPs to make sure that medical briefing is available. And the reason and the justification is really clear and straightforward, which is that it saves more lives. And ultimately, that is the public health justification. And I think it's why there's so much buy-in to this approach. The data show that there is a significant protection from both the Oxford and the Pfizer jabs after the first dose. And once you know that's true, then given that we have given we have as much supply as we have coming into the country and being manufactured in the country of the 2 doses, you want to use that as effectively as possible to save lives. So it's a public health justification.
Understand. Yeah, I do understand. Yeah. I think we've all been through it enough in terms of trying to find solutions, but it was just really the communications point, because clearly we've all been in a situation of having, really been deluged with queries from the public about it. But let me move on anyway. I understand that issue.
Absolutely. I also wanted to pick up the WHO point that you made. I don't want to go because the WHO were really they were clear in saying that they understood why we took the action that we did. And in fact, what they said, and I'm just reading this out, is that the SAGE made provision for countries in exceptional circumstances. This is the WHO's SAGE. They have a SAGE too. The SAGE made provision for countries in exceptional circumstances of vaccine supply constraints and epidemiological settings to delay the administration of second dose for a few weeks in order to maximize the number of individuals benefiting from a first dose. So, that is precisely the justification that I'd give.
Okay. Another issue around communication has been about the necessity of certain decisions and the basis on which they've been taken. To give you an example from this week, we know scientific advice favoured closing schools, but nurseries were left open. And it doesn't seem that there's been an attempt by the government this week to communicate why they're treating nurseries and early years settings differently and what evidence underpins that decision. So the question is about what you're doing to give people reassurance and publish not only the evidence underpinning closures, but the reason for leaving other things open.
Yeah, look, I think this is an incredibly important point and important question. And we publish the positivity rates by age. And we all know that children, thankfully, are highly, highly unlikely to get ill with this dreadful disease. We also know that prepubescent children are much less likely to have any degree of disease, and the positivity rates is lower. And it's lower still for very young children, for nursery age children. So that is the reason that we took the judgment that we did. And I think, it's all, we often talk about thanking teachers and of course, thanking the NHS and social care staff, but nursery staff are doing a very, very important job looking after children and helping key workers and those who can't work from home to get to work during what is a very difficult time. So ultimately, it's a balance of risks.
Yeah. Can I ask you one final question about communications then? I gather that Brexit means that young people like Alfie Dingley taking prescribed cannabis products for epilepsy and other conditions can no longer have their prescriptions filled within the EU, and their families only find this out when your department sends a letter to pharmacy suppliers. The way that your department has dealt with this has been called lazy and flippant by the campaigner, Professor Mike Barnes. Can you comment on this communications issue? Why these medicines are now being denied to people? What could be done to replace those prescribed drugs? Because young people with serious medical conditions might now be pushed back into the conditions they had before finding the drug that worked for them.
Well, as you know, I've worked hard on this issue, and we
Yes, I
have
know. Yeah.
improved supply. This is actually a decision by the Dutch government, and therefore we're obviously working very closely with them to try to change the position. It isn't a decision that we can unilaterally change from as the UK. And so we're looking in the short term at an urgent legal fix, and in the medium term, working with the Home Office and of course the Dutch government to try to find a way through.
Thank you. Could you look at how you communicate that, though, because the parents are feeling out of it and the campaigners are feeling out of it. And I think there's an important thing if you reach out to them, but I'll leave it there because I know other colleagues want to come in.
Thank you. Laura Trott.
Chair, and thank you, Secretary of State, for joining us. I want to take us forward to, if everything goes to plan, and to talk a little bit in more detail about what the situation will look like in the country and what that will mean for restrictions. So you've outlined very clearly that we are trying to get to a situation whereby we are vaccinating the first 4 groups that account for 4/5 of the death rate. So by that logic, do you expect by the 1st of March, say, so 2 weeks after you've vaccinated these groups, so when we expect immunity to kick in, do you expect deaths in this country to fall by 4/5 of their current rate?
Well, that all depends on the case rate. And of course, there's the lag. There's 2 lags here, which make the modelling slightly more complicated. The lag from taking the vaccine to getting the protection from the vaccine, which the clinicians estimate at 2 to 3 weeks, and the lag from cases to deaths, which we see in the figures, and sadly has remained stubborn, although new treatments and the improvements in clinical practice have reduced the mortality of this of COVID-19. Still, the number of cases going up inexorably leads to the number of deaths going up before the vaccine program it can be fully rolled out to those who are most vulnerable. So with those 2 caveats in the sort of in the modelling, what I would say is that I am as confident as you can be based on all the clinical advice that I've seen and all my own reading of the data, that the number of deaths in this country will fall for any given number of cases once the vaccine is rolled out to the vulnerable groups. And we're aiming for this for the 15th of February to have offered a slot by the 15th of February for a vaccination to everybody in cohorts 1 to 4. And cohorts 1 to 4 cover just over 85% of all those who died from COVID in the pandemic so far.
And what do you expect to happen to hospitalisation levels?
Well, hospitalisation levels I would also expect to fall, but ironically, not as quickly as deaths in the first instance. And the reason is that people who are slightly younger spend longer in hospital, often because they survive where somebody who's very old and frail might not survive for as long. And so I would expect hospitalizations to fall, but I'd expect to see the number of deaths falling faster at first because of the way we're taking a very targeted approach in the vaccine rollout to vaccinate those who are most vulnerable first. That is to say, the over 80s and the care home residents, and of course the NHS staff and care home staff who look after them.
Understood. And in terms of when we think about and when you're approaching relaxing the restrictions, what is obviously everyone admitted to hospital for coronavirus is a huge worry. But what is the level at which you think of hospitalizations that you think will be able to start to relax restrictions?
Well, I don't quite look at it that way. And the reason is twofold. Firstly, we've set out the conditions that we'll look at for the relaxation of the NPIs, the restrictions, which are that there isn't another major new variant that causes difficulties of the disease, that the vaccination program is working, that the number of hospitalizations and deaths is coming down. But I don't have a fixed number of any one of those four in my head, if you see what I mean. And we don't have fixed thresholds on it, but you can see the direction of travel.
Understood. And then just a final question. What do you expect the situation to be with mass testing as we move into the end of February and March? And how will that play into us being able to relax the restrictions?
So mass testing is going to continue to be very important, because mass testing, and crucially the isolation that comes with it, is a very important factor of keeping R down. Now, the lower the total number of cases, the more effective mass testing can be at keeping the R rate down. But I think that even as we release restrictions, and even as we've vaccinated the most vulnerable, mass testing is going to be incredibly important for especially for people of working age, until we get the vaccination program all the way through the entire adult population, which is of course our goal, but that will come a bit later. So mass testing is going to continue to be important. There's another way to answer the same question, which is there's really two things that mass testing does. One is surveillance, i.e. understanding where the virus is, how fast it's growing. The ONS study is the most important part of our surveillance, but obviously our genomic surveillance, where we do half the genomic testing in the world, that is incredibly important as well. That's one part. The second part is testing essentially for behavior change, which is testing so that people know that they have the disease and therefore must isolate, and then ensuring that their contacts isolate through the contact tracing system. So both of those are going to continue to be important for the months to come.
Thank you. Taiwo Owatemi.
Thank you, Chair, and thank you, Secretary of State. Secretary of State, as a pharmacist, are you able to explain why community pharmacists were not considered initially in the rollout of the vaccination scheme? Now, given that there should have been 5 points that should have been considered and how a profession is able to carry out this vaccination. First point is their experience in storage of the vaccination. And community pharmacists, as you know, have experience in monitoring fridge temperatures and ensuring that drugs are stored in the right temperature. They should have access to patient information, which is something that we do, and they have the ability to determine whether or not a patient is eligible or would have any allergies. Thirdly, they have to be able to have the appropriate training, and they have to have continuous training, which is something every year that pharmacists do. Fourthly, they have to have experience in vaccination, and even this year alone, pharmacists have done too many vaccinations in terms of the flu vaccination. And lastly, they must, which is one of the difficulties which you've been having, is they have to have close proximity so that patient can access their services. Now, given that 90% of the population are about 20 minutes walk away from a local pharmacist, as a pharmacist, we're just surprised that we were not put in the first point. We were not put in the government's mind in the national vaccination program, and the fact that we have to apply for something that we have more than enough experience to be able to do.
Thanks very much. I'm a massive supporter of community pharmacy, and I think they do an amazing job. And you set that out in terms of the job that they do in terms of the flu vaccine. And in fact, that's been growing since I've been health secretary, and indeed under the previous health secretary. The amount of flu jabs done through pharmacy has grown. Now, because of the -70 storage requirements, the Pfizer vaccine wasn't appropriate for community pharmacy. And so we are now expanding the number of pharmacies who are going to be delivering the Oxford AstraZeneca vaccine. Because of the fact that we've got to make sure that the vaccine that we've got goes as far as we possibly can. And because it comes in packs of either for Oxford AstraZeneca, it comes in packs of 800 to 1,000, making sure that we have the throughput at the sites is very important. And the good news is that we are confident that we have enough delivery sites coming on stream, whether it's the hundreds of GP sites that are already set up, or the 200 more that are coming on stream this week, the hospital sites where there's over 200, and that'll go up to 270 in England, and then more in the devolved nations, or the mass vaccination centres, 7 of which will open next week. We're with the 200 pharmacy sites as well. We're confident that we have those sites. Now we'll keep working with community pharmacy to see whether we can expand that and to see how the rollout goes and which of the different types of sites are more effective. And then there's a particular role that I think community pharmacy will be able to play, and where they will have a particular advantage, which is that the rollout has to be a universal rollout as much as is possible. And we need to make sure we get to all communities. And community pharmacies, precisely as you said, are highly engaged in their local community, often more local than any other healthcare setting. And therefore, will be able to support getting right into the communities who we need to reach. Now, GPs can do this well too, and indeed are already doing this. But there's a big role for community pharmacy, especially in making sure that this is that we reach all parts with this vaccination rollout. You're on mute, Tara.
Thank you. From what apologies. From what I understand, once the vaccine has been delivered to the vaccination centre, it can be stored up to 5 days in a temperature of 2 to 8 degrees, which is something that most community pharmacists have been doing, and that is to do with the Pfizer vaccination. So that means initially we should have been part of that plan, because that is the right storage temperature that you're meant to do once it's being given.
So for Pfizer, you need to store it for it can only store for 5 days at 2 to 8, but that includes the time to get it from the hub to the site. So when a box of 975 Pfizer doses goes to a GP surgery, they have 3.5 days by the time it gets there to use it. So you do need to have that throughput of people in order to use it and to ensure that there is no wastage. But the Oxford one is easier, and hence is more appropriate for community pharmacy, and they'll be involved in the next stage of the rollout. We're piloting it this week to make sure the processes are right, and then that'll start next week.
Thank you. My next 2 questions are based around conspiracy theories and some rumours that have been going on regarding both the vaccination and the Nightingale. So my first question regarding vaccination is, as you can agree with me, in order for the government to reach its 2 million target, there has to be public trust and there has to be public confidence in the rollout. And one of the questions that many members of the public have been asking is why there isn't a dashboard available that provides up-to-date vaccination information within people's local area for them to determine and for them to understand how the vaccine is being rolled out. Now, given that we did that with the testing, when is the government planning to roll out a dashboard for vaccination?
Yes.
Could we make that a brief answer, please, Secretary of State, just because we have to move on?
The honest and true answer is, as we grow this programme, we're going to put out more and more information into the public domain. When you start a big programme like this, the first thing to do is get the straightforward verified information. How many vaccines have you done? We started it on a weekly basis. We're moving to a daily basis, and we'll put out more and more of that sort of information as the programme grows.
Thank you. Dr. Luke Evans.
Thank you, Chair. Thank you, Secretary of State. My questions are around risk. The COVID alert level 5 definition states material risk of healthcare services being overwhelmed. What's your assessment of the absolute risk to the NHS at the moment in a percent? Are we 10%, 50% likely to hit this in the next 2 weeks?
It's impossible to put a number on it. And I don't mean that just as a cop-out. I mean that in reality, because what happens is that as the NHS, this is better, better than anybody being an NHS doctor, but as the pressure on the NHS grows, so it is more stretched in delivering the services that people need. And, you know, we've seen in this second peak that the, areas have had to cancel routine electives. First, what are so-called P4 electives, that is those where a delay may be uncomfortable but isn't a problem. And then P3, where they really ought to be done in the next 3 months, but it's okay if they delay a little. And so, that is the pressure.
Secretary, you probably saw the leaked document about what's going on in London. Do you have every faith that we're able to cope in London with the NHS?
Well, yes, I'm sure that the NHS is going to do everything that it possibly can to ensure that everybody gets the care that they need. And of course, firstly, in London, we have built significant more critical care capacity over the summer. We spent the summer extending critical care capacity. And then obviously, we also have the Nightingale on standby. There were some rumours that it had been decommissioned. They were wrong. The Nightingale is on standby. But of course, the Nightingale is the physical capacity. We also need the people, and hence bringing people back into the NHS, and also, ultimately, people, when hospitals are busy and full, then clinicians become more stretched, and that's why we should be also grateful for the service that they're giving.
And moving on from, Laura Trott made some points earlier talking about the ambitious plan to get 13 million vaccinated, which is fantastic. And you've talked about the 85% change in the risk there. Do you have a concern, though, about what that means for the population who aren't vaccinated, who don't see the virus as such a risk, and how they will behave?
We've always got to monitor these sorts of behaviours. What I would say, though, is that especially in this national lockdown situation, people are by and large very, very respectful of the rules. There are some people who break the rules, of course there are, but generally, compliance has been good, and that's very, very important because it's the only way that we can control this until we have the vaccine rolled out. Now, when the vaccine is rolled out more broadly and vulnerable groups protected, I hope that people continue to be, respectful, and also take personal responsibility for trying to reduce the spread of the virus, because that way we can lift more restrictions.
Now, Prof. Whitty talked a lot about the fact that society is going to need to have a discussion around the risk, a bit like we do in traffic. What's the right speed limit? How do we approach dualling carriageways, things like that? What conversations are happening in government around facilitating this? When do you see it coming into play? Because many people, like the hospitality, the businesses, will be thinking, when the vaccine comes, we need to get back to normal. When is that right point going to come? I appreciate you can't answer that directly, but the discussions are really important in how we feed in.
Yeah, I think that we need a national discussion about it, frankly. Of course, government has a view, and both the clinical advisors to government and also as politicians, because ultimately these are political judgments in the best sense, as in weighing very big concerns and balancing big judgments based on the best clinical advice. And Parliament has an important role, and indeed this select committee, I think, will have a very important role in balancing those considerations of how we deal with this over the medium term. We've seen with the new variants that, like flu, it is likely that we're going to have to, that when a new variant comes, thankfully, there's no evidence yet of one that will escape the vaccine. But should that happen, then we'll need to iterate the vaccine in the same way we do for flu. It's totally normal for flu. We've done this for decades. And that's where this will end up. But the path of getting from here to there, taking into account all the other impacts, the economic impacts and the other health impacts of the actions that we have to take, that is ultimately a national debate.
Thank you, Chair.
Thank you. Sarah Owen.
Thank you, Chair. Following the death of Mary Agyapong, a pregnant nurse from Luton, her husband, Ernest Boateng, started a petition which has now over 100,000 signatures on, calling for greater protections of pregnant women throughout the pandemic. We saw a doubling of stillbirths in the last lockdown. Are there plans to review the guidance and for shielding to go before 28 weeks?
Well, this is very much a clinical question, and my heart goes out to those who are affected. It's just one of the many awful things about this disease, but it's absolutely one where I'd take the clinical advice. And it's Dr. Jenny Harries who leads on this question. And I think that the approach we've taken to shielding, which we've learned from some of the negative impacts of shielding first time round, and we've iterated that based on the clinical advice. If there's a specific advice to make a change in here, in this area, it hasn't reached my desk yet. I don't know whether Clara Swinson wants to come in on the details.
Thank you, Secretary of State. It's in terms of the definition of the clinically extremely vulnerable, obviously almost a year into this pandemic, we know a lot more about that. And as the Secretary of State said, the Deputy Chief Medical Officer leads this work, and we'll be looking at both at the overall cohorts of people, but also the individuals for a conversation for those at most risk, including pregnant women, if that's appropriate.
Thank Clara, you. Could she write to us with her latest view on that and whether it's changed?
I'm sure.
Thank you.
Thank you. My second question, Secretary of State, there is a big difference between offered and delivered. How many vaccines are you hoping to deliver by mid-February to the top 4 priority list?
Well, I would love it if uptake was 100%. That ultimately, that would be wonderful. And we're not going to let up. We want to make sure everybody gets this vaccine, unless they have a very specific clinical reason not to, which is where there are some exemptions, but they're very rare. So I can't put a figure on that because I want it to be as high as possible. The point about the exact language of the target is that people will be offered to have had the vaccine. So it's not that you might get an offer on the 14th for a vaccine in a couple of weeks' time. It is that you will have been offered to have had the vaccine by the 15th of February. If that makes sense? And I want everybody to take up those offers.
So they would have had the opportunity, 13 million would have had the opportunity to have had the vaccine by mid-February.
Yes.
Okay.
So the word offered is not there to imply that we could write you, we could say that we'd hit the target by writing you a letter.
Or posting testing kits.
And making sure that the offer is available. It's that you will have been offered to have had the vaccine by that date. And the reason we use the word offered is because, of course, if somebody refuses to have the vaccine, I think that that's a mistake if they don't have a clinical reason, but we are not seeking to mandate the vaccination. So I can't, as Secretary of State, reasonably be, reasonably set a target of having vaccinated all those people, because unfortunately some of them won't take up the vaccine, even though it's the right thing to do.
Thank you. And is there a plan for if a new variant comes which does not react well to the vaccine? What is the plan for the next year, 2 years, also while we're rolling out the vaccine?
Yes, we're working precisely on this question. And the answer is, as with the flu vaccine each year, that for a given vaccine platform, for a given type of vaccine that's been clinically trialed and approved, if you make small adjustments to it, then it may not need the full year-long trials process that that a new vaccine needs. That, of course, is a decision for the independent MHRA. And the way I've put it in public is that the way I've described it is that, if you have a car, say, if you're lucky enough to have a Range Rover and you get a new wing mirror stuck on it, it's still a Range Rover and it should be classified as such. In the same way, if you make a small change to a vaccine, it's essentially a regulatory clinical decision as to whether that needs to go through the full panoply of the full 3 phases of clinical trials.
Thank you very much. Dean Russell.
Thank you, Chair. I would like to ask about some of the long-term impacts, but one of the long-term impacts that I'm very aware of from speaking to everyone from schools through to people in the community and emails is the impact on mental health. Could you please just outline what measures are being undertaken right now to help support mental health of the nation?
Well, yes, this is incredibly important, and I'm acutely aware of the mental health impacts of bringing in a lockdown. To Dr. Evans's question earlier, and indeed the chair's at the start. So we're putting in place more support for mental health services this year than last, and there'll be more to come. And I was very glad that the spending review that the Chancellor announced more support for mental health services. In addition, we've got to make sure over the medium term that we update our laws on mental health. And so I can tell you that next week we'll be bringing forward the mental health white paper, following on from Sir Simon Wesley's report that he published just over a year ago now, and we're taking on board the vast majority of his proposals, and indeed adding some further. And I then hope to be able to legislate a new Mental Health Act in this Parliament to replace the 1980s Act, which is now very much out of date. I hope this is a highly consensual process, very much an open book approach. And I'm sure that the Select Committee will have an important role in making sure that we get the details right. And so I'm very grateful for the whole team and all the stakeholders we've been working with, that we're able to get to the point where we'll be launching this next week.
That's excellent news and very welcome. Can I ask a bit about long term? Professor Whitty has talked about the vaccine. Obviously, it's not going to be one you take it once and that's it forever. But also talks about measures for next year. When we look at this time next year, where do you think the country will be? Will we be having a national vaccine rollout programme? Will we still be doing testing? Is the economic measures of that been looked into as well?
There's absolutely no doubt that vaccines and testing will still be a feature next year. We'll need both the surveillance testing to be able to understand where the virus is, and we'll need testing for people who have symptoms in the same way that you get tested for all sorts of other things. And in fact, I want to have more testing. I've talked to the Select Committee before about the dictum of, if in doubt, get a test, should apply across the board. It should apply to flu and other illnesses, and as well as COVID-19 and other coronaviruses. And then on the vaccine, I anticipate that we will probably need to revaccinate because we don't know the longevity of the protection from these vaccines. And that might need to be we don't know how frequently it'll be, but it might need to be every 6 months. It might need to be every year. As with the flu jab, we vaccinate every year and we update it according to any mutations that have taken place. And we do that over the autumn because although you can catch flu in the summer, it's highly unlikely. It's because the lower ventilation and much more time spent indoors that flu transmits more easily during the autumn. So I anticipate COVID and flu vaccinations, long into the future.
And just looking ahead to give a bit of relief, both on mental health and the light at the end of the tunnel, do you foresee this being the last of the lockdowns now that the vaccinations are being rolled out?
I do, yes.
Thank you. Thank you, Chair.
Thank you very much. Rosie Cooper.
Thank you, Mr. Chairman. Secretary of State, how many doses of vaccine have been wasted or unused? And have you considered allowing anybody from the first 4 tiers being called in to use those doses rather than rigidly finishing each tier before starting another, to make sure that nothing is wasted? And what's the current position for getting tests for the asymptomatic who are shielding or disabled and can't get to a centre? Are they still available by post?
The answer to the last question is yes. The home channel is working well, and we have spare capacity in the testing system, both in terms of PCR tests and lateral flow devices. In terms of the first two questions on the use of the vaccines and on wastage, obviously we want to minimize wastage, and that goes without saying. Actually, we've changed the guidance very recently in the last few days, so that if it's possible to draw 6 doses from a vial, rather than the standard 5, if you can get 6 full doses into the syringe, then you can do that. And that, in fact, in many practices, that's what they're doing. I was at the Bloomsbury practice this morning, and they were drawing.
Secretary of State, I'm not talking about the number, I'm talking about the numbers that don't get into arms. So how can we make sure that those 6 doses actually are used and not wasted? So how are you getting the throughput?
Yes, I was coming on to this because they are linked. Because, you know, if you can get 6 doses out of each vial instead of 5, then you increase your total amount of doses by 20%, which is obviously good news. Now, then the second sort of the second question, the second part of the answer, in terms of the making sure there's enough people then to put that vaccine into, the advice that we give to centres is that they should use that any spare doses that would otherwise go off, they should use them primarily on NHS and social care staff. So in hospitals, that's often easy because there's lots of NHS staff around. The primary care networks have got links to social care to invite social care workers in at the end of the day or at the end of a box if they're getting to the point where they're where the time on the box is running out since it was defrosted. And so in the first instance, whilst we're currently vaccinating groups 1 and 2, one of the reasons that we're taking groups 1 and 2 together is in order to be able to ensure that we minimize wastage by inviting NHS.
State, I get that. So we're not allowing them to move across the tiers is the question. I'm just anxious because of time, because there's a couple of things I want to get through as well. The BMA have called for all health and social care to be staff to be vaccinated by the end of January. You talk as if that's going to happen, and I just wondered whether you've made assessments about the workforce challenges over the next 3 months. The same exhausted group of people are doing the caring, the nursing, the vaccinating, and I hear today the unions have offered help. Are you going to use the army? How are you going to quickly get through that? I'd appreciate a short answer because there is one final question I'd like to ask you.
Well, look, of course I understand the workforce pressures. Hence, we're trying to bring more people in, and I've taken out a whole series of the, I thought, overburdensome training requirements. So you no longer need to do fire safety training and anti-terrorism training to get back into the NHS to do vaccinations. But there's a broader workforce point as well, because it isn't just about what we're asking the NHS to do in terms of vaccines. It's also about what's happening in our hospitals, which is that there is very significant pressures.
Okay, finally, Secretary of State, the government have increased dental charges on patients and activity targets and practices out of sync from January this year. Dental practices can't get up to anything like the levels they were because of social distancing, decontamination between patients. That could be reduced by high quality but expensive ventilation, unaffordable for most dentists. It's clear that the dentists are facing an existential threat. Wales has committed 450,000 for ventilation. I've asked about this in Parliament. Other than talking about it, what are we doing to really help dentists get back up to scratch? There are 20 million lost appointments last year.
Yes, we've funded dentists all the way through the crisis, and we do require that there is that funding now, unlike in the first lockdown, that funding is partly in return for activity, whereas in the first lockdown, dentists were closed, but they were funded nevertheless. And so that's the approach that we're taking. Of course, the ventilation is important, and the PPE is free. But I really hope that we can keep dentistry going through this second lockdown third lockdown, as we did in the second lockdown, rather than closing them as we did in the first.
Thank you. Neil Hanvey.
Thank you very much, Chair, and thank you, Secretary of State. Clearly, we're not in a place that any of us want to be, and I don't want to go over political points about U-turns and the like, but I do want to talk a little bit about the government's approach and how we forward plan from here, and hopefully you take stock of how we got to where we are. I understand completely your desire to ask everyone in the chamber to get behind the government and to move forward as collectively as possible. And I can assure you that certainly many of my colleagues and others on the committee will be doing as much of that as they possibly can. But when those appeals to get behind the government strategy are made, it's very difficult to do that when people like myself who've got significant clinical and management experience in the NHS or are esteemed clinicians in their own right, when they ask questions that are completely logical and sensible questions, but they're rebuffed in a way that may be considered discourteous at times, that doesn't really certainly engender a collaborative or collegiate response. And I just wonder how you feel you may be able to improve that sense of collective endeavour and you know, perhaps give us the kind of answers that we hope to get. If I can give you an example, I've had briefings from interested groups today asking me very specific questions that they want answered, but because I struggle sometimes with the confidence of the quality of answer I'm going to get, I need to talk to you about the way that we operate in this pandemic. And so I guess my question for you is there any way that you can improve the communication, particularly in the chamber, so that we do feel that there's a shared sense of endeavour?
Yes, I'm absolutely up for that, Neil, and I think you put it well and diplomatically, if I may say so. Sometimes the debates in the House of Commons chamber are robust, but I think, frankly, over COVID, it's been very largely about all of us pulling together to try to get the right outcome. I mean, after all, you know, you represent a seat in Scotland. The strategy of the Scottish government and the UK government are closely coordinated and essentially the same. There are, of course, adjustments because there are different circumstances, as with in Wales and Northern Ireland. But nevertheless, we work very closely with the devolved nations. In fact, after this, I'm going to have a call with Jean Freeman, who's the Cabinet Secretary for Health in Scotland. Now, the other thing we do try to do is talk privately as well. And so, for instance, on Tuesday morning, I held a private briefing, cross-party briefing for MPs following the new measures in England. So essentially the answer's yes. Let's work together as much as we can.
Okay. Well, then in that regard, so at the beginning of February and at the last meeting that we had where you attended, I was assured that I would receive further information on lateral flow tests that would assuage my concerns. I've still not received anything from the department on that, and I still have outstanding and quite significant questions, written questions about the protocols that were followed for the Liverpool study, if I can call it that, because until I see some research protocol, I struggle to call it a study. But I think the fundamental issue is, will you please attempt to answer questions as best you can in the chamber rather than get into a combative response? It's really not helpful. That's my plea.
Yes, yes, no doubt. I'm absolutely up for that. In fact, yesterday I ended up correcting my Labour opposite numbers speech as we went along and making suggestions, which was some of the newspapers thought was amusing. So Neil, I'm up for that constructive dialogue if you are.
Thank you.
Thank you.
And I'll get back to the point I made. You should have got your reply by now.
I can guarantee you'll always like the question, however.
Okay.
is well intentioned.
That's the nature of democracy.
Thank you. Dr. James Davis.
Thank you, Chair, and thank you, Secretary of State. Firstly, a question about rapid testing. Can you tell us what percentage of frontline NHS staff now have access to twice weekly lateral flow tests, please?
In England, it is, I'm told it's 100%.
Fantastic.
Now,
Okay.
if somebody hasn't been given them, then let me know. But we've supplied 100% to the front line in hospitals.
Okay, because they're yet to roll out in North Wales at all, but that's very interesting. Thank you. And in terms of vaccination, can you tell me when you anticipate knowing whether those who've been vaccinated are still able to transmit COVID?
That is an incredibly important question that I don't know the answer to, I want to know. So obviously we have a pharmacovigilance program to follow people who've been vaccinated. It is the hardest question to find out whether they still transmit for obvious reasons, but we are studying that, and I will write to you as soon as I know when we'll know. In fact, I might ask the CMO to write to you, doctor to doctor, with his best estimate of when we'll be able to assess that. We won't be able to put a date on it yet, I'm sure, but it's about how we will get to that assessment.
That would be much appreciated. Next question, capacity of vaccine production to meet our targets. Do you have concerns over the availability of the vaccines?
Well, obviously, we'd all want more vaccine to be available, but I want to be really clear about what the challenge is here and where the rate limiting step is, because we have, as we were discussing earlier in the session, we have hundreds of places across the UK that are vaccinating, and that is not the capacity constraint. The capacity constraint is the supply of the approved vaccine. That doesn't mean there's been a delay, and it is not a criticism at all of the manufacturers. They're working as fast as they can. It's that making this stuff is hard. I said in the chamber yesterday, it's a bit like if you're into your baking, it's a bit like you're growing your yeast. It's a biological process. And so that that is the delivery schedule, and we're delivering the kit that we've got, and that's where the constraint is.
Understood. And finally, there's huge interest, of course, in the priority groups, the JCVI priority groups for receipt of the vaccine. Now, I know there are 9 groups within phase 1. We're working through, and hopefully we'll reach level 4 by mid-February. But you'll be aware of calls from teachers, from those who work in nurseries, from those who work in funeral directors, the police and so forth. So essentially people who have contact with people on a regular basis to be given some kind of priority. Now, I know currently they feature under phase 2. What is the political process for agreeing the priorities there? And do you think there's any prospect that some of those individuals might move up alongside groups in phase 1?
The JCVI prioritization is really clear, and we are committed to vaccinating according to that clinical priority. The order after that clinical priority, essentially for the under 50s who don't have conditions that make them particularly vulnerable to COVID, that is not yet decided, and I'm sure that it will be debated, and then we'll come to a decision. I think that teachers and nursery workers have a good case to make, as do the police and other public servants. There's key workers across the board. So that is a debate that we will need to have and come to a decision on.
Thank you.
Thank you. And we've been making excellent progress. Last but not least, Paul Bristow.
Thank you, Chair. Secretary of State, the BBC have reported that King's College Hospital Trust have cancelled all priority 2 operations. That's those operations that doctors say need to be carried out within 28 days to either save life or stop disease progression. Given NHS capacity issues, is this likely to be repeated in other parts of the country?
Well, we obviously try to minimise that, but it has happened elsewhere in the second peak, and of course in the first peak as well. And it is an indication of the degree of pressure that London hospitals are under. So it's a big challenge, and it reiterates the central importance of people following the lockdown and restricting as much as possible the contact they have with other people.
Time and logistical challenge for our NHS. Will this have an impact, do you think, on other NHS core services, such as GP availability, GP referrals for urgent treatment, such as cancer? What do you think the unintended consequences of the NHS focusing all its time, rightly, or a vast majority, a significant proportion of its time on the vaccination programme could be on other core services?
Well, we've obviously considered this very carefully, and one of the reasons that we're doing this through groups of GP practices, through the primary care networks, is that then most GP practices are contributing to, but not having to take full responsibility for a COVID vaccination centre. So essentially, groups of GP practices are coming together and each lending a number of people to create the COVID vaccination team. And that allows us to keep as many GP services, normal GP services running, but obviously that has to focus on the most important healthcare needs. And indeed, we took clinical advice on the relative importance of vaccination compared to other things that GPs need to do. And the NHS, led by Dr. Nikki Kanani, who is the NHS's top GP, are advising GPs on how to do this. But ultimately, a lot of it will be down to the individual judgments of GPs in practices right across the land. And it's exactly the sort of judgment that GPs are trained to make, which is how to assess the order of priority of different patients, where there is just a very large chunk of COVID vaccinations to get through for a whole load of their patients. But in addition, from next week, we'll be opening these 7 major vaccination centres to be able to get really high throughput and take some of that burden off the GPs, as well as using the community pharmacists we were talking about to make sure that we can get through the vaccination programme as quickly as supply allows.
Okay, and just one final question, if I may. Obviously, the NHS is being impacted by staff shortages due to COVID. And so I'm just interested to know what effect you feel this is having on the delivery of other core services, such as cancer, etc. And then with this in mind, and you've touched on this already, just to make it very clear, but with this in mind and staff shortages becoming a feature, certainly at Peterborough, is it time now to prioritise all NHS staff for vaccination in the coming weeks?
Well, we absolutely will ensure that all NHS staff are offered a vaccine in the coming weeks. I mean, certainly by the 15th of February, because they're all in category 2, and therefore that's the target. And I very much hope that the uptake amongst NHS staff will be right at the top level. We've seen this year a record uptake in the flu vaccine amongst NHS staff, and over 80% of over 65-year-olds taking the flu vaccine, which is 10 percentage points higher than last year, which itself was a record high. So, we are seeing that very high level of take-up. With NHS staff, they will all be offered a vaccine over the coming weeks. I hope we can get through all of category 2, which includes all health and social care staff, sooner than 15th of February. But that's the target that we're committed to hit.
Thank you. Secretary of State, we are very conscious that this is actually a nightmarishly challenging week for the NHS. So thank you for giving up your time this afternoon. But could you also please pass on our thanks to all NHS and care staff who are going the extra mile, working incredibly hard this week, the most challenging week probably the NHS has ever had. We're incredibly grateful for their service. But thank you for your time this afternoon. I declare this afternoon's meeting over. Order, order.
Thank you.
Thank you.
Thank you.